This is Emily Peters recording neuromuscular disorders for advanced concepts of OB peds. This is broken up between chapters 16 and 22 of your Essentials of Pediatrics book by Kyle and Carmen. So there are many different factors that affect neurological disease in children. Prematurity, issues that are related to or caused by difficult birth, infections during pregnancy, signs that we would see that maybe mean we have a neurological disease would be that nausea, vomiting, and headaches, changes in gait. Falls, if we've had like head trauma, or a child that's falling frequently could give me a sign that something is going on if they've never fallen before. And they're starting to develop visual disturbances that are unusual. Some neurological diseases are structural defects, and then we have the things like seizures disorders, which, if you recall, seizure disorders typically are caused by factors outside the brain, such as that high fever, infection, head trauma, hypoxia, toxins, or cardiac arrhythmias, unless it's epilepsy. Epilepsy seizures are triggered recurrently from the brain, so it's due to something going on in the brain. Common infections that can lead to neurological issues are meningitis, encephalitis, and Reye syndrome, or Reye syndrome. Okay. So these are some of those common laboratory and diagnostic tests that we do when trying to figure out what is going on with somebody neurologically. On page 507 through 509 are several of the laboratory and diagnostic tests that we have listed here. Lumbar puncture, which we know is testing the cerebral spinal fluid. Head and neck radiographs are detecting fractures, different abnormalities, structural issues, things like that. Fluoroscopy is another form of a radiographic image that it's more of a continuous x-ray that shows live, up-to-date images. It kind of gives you an idea of instability, and you can kind of watch move the child while you're taking the x-rays. Things like that. Cerebral angiogram or angiograph is an x-ray study of the blood vessels. So we'll use a contrast medium and the fluoroscopy. Ultrasounds, which are used to locate the depth and structure, the depth, and the soft tissues. Typically, ultrasounds are used to assess for intracranial hemorrhage, the size of the ventricles, things like that. But you can also look for the swelling, fluid buildup, things along those lines. Computed tomography, or CT, is one of those non-invasive x-rays that looks at tissue density and structures. If you've seen a CT before, it's kind of giving you slices of the brain or slices of the part of the body they're looking at. Let's see. EEGs check the brain electrical conductivity. MRIs are magnetic resonating imaging, is using magnetic fields to show the tissue composition. PET scans are like a CT and MRI, but a radioisotope is used, and that kind of gives you an idea of what the physiological functions going on. Intracranial pressure monitors. It's a sensing device that is placed in the hand and monitors that pressure. We sometimes use these right before delivery. They can put it's not an intracranial pressure monitor per se, but they do put it in there on the head, and it kind of gives you an idea of what's going on. But we do put these in when kids have had, or adults have had, major brain injury to see how much fluid is building up. Okay. So there's several different tools and things we can do to help our patients. These are some of the common medications or types that we use for neurological disorders. Antibiotics, that's going to treat whatever that infection is, such as like the bacterial meningitis. Anticonvulsants, as we know, decrease the hyperexcitability of the nerves. So they are used for treatment or prevention of seizures. Benzos, like diazepam or lorazepam. It is like a sedative. It prevents or stops seizures from slowing down the CNS system. Analgesics for pain. They block pain. Osmotic diuretics such as like mannitol. That increases our plasma osmolality, and that helps to induce diffusion back into the plasma and extravascular spaces to reduce ICP or intracranial pressure in our patients. Corticosteroids will help suppress inflammation, and it also suppresses normal immune response and reduces cerebral edema. Okay. These are all broken down on page 5 of 2 of your book. If you don't remember what these are, and some of those nursing implications when we're giving these meds. All right, so these are some of the common medical treatments for neurological disorders. Shunt placement. That's a catheter that is placed in the ventricle to pass the CSF fluid to the peritoneal cavity, possibly the atrium of the heart or the pleural spaces. It's used for like hydrocephalus or kids with increased intracranial pressure. We need to be monitoring for signs and symptoms of ICP, watching the neurological status, their level of consciousness, and their vital signs. We need to look for those signs and symptoms of infection. So signs and symptoms of infection would be those elevated vital signs. In babies or even older kids, you might start seeing poor feeding, vomiting, decreased responsiveness, seizure activity, which hopefully we don't get that far. We'll also see signs of local inflammation along the shunt track. And I will try to point out when one of the pictures that I have later on in this PowerPoint what the shunt tract is. Ventilation. Hyperventilation is to decrease the PaCO2, which will result in vasoconstriction and therefore decrease ICP. Why am I going to use it? A child has high ICP, so I want to decrease it. So I'm going to ventilate them and decrease, some of that workload that they are going through. PT, OT, and speech therapy. These are all to help improve the motor function of the children. So they can have intellectual disorders. They can have slowing of their ability to do normal movements after they've had the head injury or whatever is causing them problems, and so we need to work with them so they can regain that strength and relearn how to use their body appropriately. External ventricle drainage. It is a catheter that is temporarily placed in the ventricle to drain the CSF fluid. It's a closed system, and has an external reservoir, so the reservoir is on the outside of the body, whereas with the shunt, like I said, it is drained. A tube stays on the inside of the body, and it drains within the body systems. Ventricular tap is something we will use to reduce the accumulation of CSF and decrease ICP. So, for instance, we will tap into the ventricles, and we will pull off the fluid. Typically, the neuro doctors do this. And that, therefore, by taking off that extra pressure or extra fluid, that takes off extra pressure and should decrease the ICP. Vagal nerve stimulators are really interesting. This is a lead wire that is implanted and wrapped around the patient's vagus nerve. So when the patient starts having a seizure or has like an aura or one of those things that they see when they a seizure is triggered or they're feeling, they use this like magnetic key that they put over top of the vagal nerve stimulator, which usually it's implanted similar to like a pacemaker in the chest, and then that lead wire goes from that pacemaker type of machine and is wired up and wrapped around that vagus nerve. And then all they have to do is put that key up and over where the box is under their skin, and when that key goes over it, it triggers kind of like a shocking or a stimulation to that vagus nerve, and it is supposed to stop that seizure. And then we have ketogenic diets. Ketogenic diet is a high intake of fats, a decent amount of protein, and very low intake of carbohydrates. This puts that patient in a ketosis type of state, and they're kept slightly dehydrated. This is used for prevention, control, and reduction of seizures, especially in those kids that have difficult to control seizures. So, structural defects. These are some of the main structural defects that we see. Neurotube defects, microcephaly, anencephaly, Arnold-Chiari malformation, hydrocephalus, intracranial arteriovenous malformation, and craniostenosis. We are going to discuss the neurotube defects, microcephaly, and not microcephaly, anencephaly, and then hydrocephalus. So this is anencephaly. This is the most severe case of a neurological defect in a way. You have an absence of the cranial vault or an absence or very small cerebral hemispheres, and a lot of the times they don't have the full overlaying skull. This occurs when you're having a failure of that anterior end of the neurotube to close. Anencephaly is considered incompatible with life. You can see this when the child is developing on ultrasound. So this should not be a surprise to the family. One of the things we do when we find out we are pregnant, and we should be doing it even before then when we are in those fertility period of our life, so the fertile period of our life, so high school, even junior high, through whenever we're hitting menopause, in case we have children or get pregnant, is we should be taking folic acid. It's not 100% in preventing the anencephaly, but it is one of the big things that helps reduce the chance of a child developing a neurotube defect. There's a lot of controversy with anencephaly. Well, if we know it's going to happen and it's not compatible with life, why are parents carrying this baby to term? Should we just abort? Should we, and terminate? Should we carry to term or to however long we can have the pregnancy last and then deliver the baby? Some will be alive at birth and then die soon after. Some will live for a while and then pass on. I have heard cases of kids that have lived into early childhood, some that have only lived a few days, some that have only lived a few months, and a lot of them are stillborn. It is up to each family what they want to do, and make that decision themselves of whether to abort, carry to full term, or to that delivery stage, or to, whatever their choices are. We as nurses need to support them and to support their decision. We shouldn't judge them. Okay? We will do comfort measures. We will allow that parent to bond, whether the child is born by stillbirth or if that child is born and breathing. This kid can breathe on its own, but most of the time they don't have a lot of abilities to have, because of what parts of their brain is missing, they don't have a lot of quality of life. So for instance, will they be able to walk? Will they be able to talk? More than likely no. Are they going to be able to eat on their own? Some can. Will they be able to, some kids can eat on their own and take a bottle fine. They're usually able to breathe on their own. It's the rest of their body they're not able to control. So they are going to be pretty much a child that is going to need 100% care. Now there is on Facebook a family that has a little guy named Jackson. It's called Jackson Strong or Jack Strong. He has a different form of anencephaly. In fact, I don't think it is truly anencephaly because he does have quite a bit of his brain, but part of it's missing. I think it's a correlation between microcephaly and anencephaly, and they're doing lots of treatments and therapies with him, and he is starting to talk and make sounds and grab things and move around. I think he's close to 1.5 years now. So there's those stories out there. We don't know how long kids like him will live. So we need to think about, what do we do for families who are losing a child? We comfort them. We talk to them. We allow them to bond. If they wish to have a baptism, we help them bring in and do their baptismal rituals. Do I have to pray with them? No. Do I have to be involved in whatever their religious ceremony is? No. Do I allow them to do those things? Yes. As long as it's not disruptive to the unit. We don't push them out immediately after the death of their child. We give them time to cope and to spend time with that child and to have some grieving. If we know that we need their room, we find someplace else in the hospital for them to spend that time. So for instance, on my unit, we do have a room that we consider like a conference room, but it has a spot for a crib and a couch and a chair and a desk with a phone. So that if I need the baby's room, we can then move them into that room and they can have the crib with them. They can pray, they can do whatever it is. They can bathe the child, bond, cope. We give them hair samples if that child has hair. We will do footprints and handprints. Give them memories. We'll sometimes have photographers come in and get pictures taken so they have those memories. Whatever we do, we don't push them out. We will even get them food and drinks so that they don't have to leave and they can be taken care of. So death can be very hard. We all have to figure out different ways to cope with it. When we take these kids to the morgue, most of the times we have wrap the child up in blankets and we cover everything and then we take them down to the morgue. Sometimes, unfortunately, we will put them in a bag so nobody knows I'm carrying a baby or a child, but it's not like an obvious thing that it's like a body bag. Because anybody that would see that there was a lost child or infant are going to react differently than they would to an adult patient that has passed, and they see that being pushed. We typically will transfer these patients through elevators and things that are staff only, and hopefully we won't pass anybody in the hallway. Try to think about some other things that you would do or like to do or would need to help comfort in that loss. I go to funerals sometimes of the babies that have been lost, because that's a way for me to grieve. But I also don't always get involved with some of those ceremonies if it is something that is against my beliefs. So, for instance, I'm Christian, and if it were to be a ceremony that I'm not comfortable being at, I won't go, but I will allow the parents to be there. Now, if they do ask me and they really want me to be there, I will be supportive and be quiet and be there and present to support them. But I don't usually get involved in whatever the ceremony is. Have I prayed with patients before because they've asked me? Yes. But that is something you don't necessarily have to do. Okay. Hydrocephalus. Hydrocephalus is an increase in that cerebrospinal fluid in the ventricles of the brain. The normal body produces about 400 to 600 milliliters of cerebrospinal fluid each day. With hydrocephalus, something is going on that doesn't allow for the cerebrospinal fluid to be absorbed or removed from the ventricles of the brain. And so we keep producing our 400 to 600 milliliters a day, but it's not leaving that space. One of the ways it leaves that space is down through our cerebrospinal tract, right? So something's causing it not to be able to drain. This can be caused by intrauterine infection or a malformation in the brain, something. Hydrocephalus often goes hand in hand with children with myelomeningocele. Myelomeningocele blocks the flow of the cerebrospinal fluid. We will talk about myelomeningocele in a few slides. So when I'm assessing my child with hydrocephalus, I'm going to be assessing and feeling their head, and I will be able to feel the bulging anterior fontanelle. I will be doing that head circumference, and I'm going to be seeing that it's increasing at a normally fast rate. And then that results from increase in the cerebrospinal pressure. One thing babies have built in when they have increased fluid is those bones aren't fused. And so they do have a little bit more space and room for growth. So they don't technically get that damage to the brain quite as fast, but it happens fairly soon if we don't intervene. Okay. As the fluid builds and builds and builds, you start seeing even more enlargement of the forehead. You end up with these depressed eyes that are rotated downward, causing like a sun-setting sign. How do I help these kids? Well, one big thing is whenever I anticipate that this child has hydrocephalus or increased intracranial pressure of the head, I am constantly doing my head circumferences. That's one of the biggest things I can do in my assessment. Okay, I notice there's a neurological issue. I notice something's going on. Measure that head, measure that head. Okay? To get rid of the fluid, we will put a shunt in. It's going to be that internal shunt eventually. Sometimes we'll just do those ventricular taps until we can get that child stabilized for surgery. And then we'll put that shunt in, and then they have the shunt track that is built in, and then it'll go down into the peritoneal cavity. And then that'll slowly start draining that cerebrospinal fluid. We want to prevent further neurological damage, but we're not going to prevent all neurological damage because before we intervene, there could have already been damage. So basically, we're reducing the likelihood of irreversible damage. What am I going to see that is going to tell me that this kid has increased intracranial pressure? Those widened sutures, the fontanelles, distended scalp veins. They're lethargic. They don't eat well. They're vomiting. They're irritable. And this high-pitched, shrilly cry. We can see hydrocephalus on that fetal ultrasound. If it isn't severe, we don't always detect it. So, interventions. First of all, you're looking at this little guy. He's a little bit older of an infant. He's probably getting closer to that year stage. You can tell how big his head is, and his forehead is starting to bulge out. You can see, let's see. You can see how he's bulging out right through here. Okay? And the pressure of that is building right through here. And it's starting to push down on his eyes, so therefore his eyes are starting to slant downwards. Sorry, I'm not the best drawer. Okay, so what do we do for this kiddo? Well, we're going to, as nurses, measure the head circumference. We're going to be doing our good neurological assessments. So I'm going to be seeing if he's responding to pain. Is he responding to sounds? Can his eyes dilate? Is he able to suck? Is he moving around? What is going on with his vital signs? What is his respiratory rate like? Okay. Think about a child. Their heads are large anyways. these kids' heads are even larger, and they can't control them. It's even as they get bigger because it's too big for them to control. They can't move around very easily, so we end up making sure these kids have special pressure-sensitive mattresses to help with skin breakdown and decrease pressure points. We're going to do frequent position changes with these kids as well, because they're not going to be able to move around as much to help with that skin breakdown. Okay, I am going to be making sure this kiddo is eating frequently. If he can't eat on his own, I may be putting an NG in. If it's a long-term thing, we might put a G-tube in, because nutrition is important as well. Hopefully this kiddo, he does not have a shunt in yet, will get a shunt. If not, I don't know what they will do for him. It's probably one of those poor African countries where who knows, unfortunately, what his outcomes will be. Okay, so this little guy has a shunt in. His shunt is right here, and the shunt track is right through here, and then it goes down and around through the front of him and down into his peritoneal cavity and down into his stomach. Okay. Can I erase these? Okay, I'm going to erase my blue line. Okay. And a little bit of my red. I'm going to redraw that so you can see the incision. Okay, do you see that incision there? Okay, I'm going to watch where that incision is. That should heal up pretty quickly. But it is a little elevated right through there. But that shunt tract will always stay somewhat raised like it is. We don't see it very well with hair because the hair will cover it. Where you will start to see it a little bit more obvious is when you start getting down to below the hairlines on the neck and behind the ears. That is where we need to teach the parents to be watching when they're brushing the kids' hair, giving them baths, is to be kind of looking in through there, because we're going to start seeing, we hope we won't start seeing that inflammation along the shunt tract. I've seen these get really red and swollen and bulge out even more. But we should see some earlier signs of the kids not eating as well. They're vomiting. They don't seem to be responding. But sometimes we don't see those things and the inflammation starts first. Boys is when you boys are the kids that you usually can see them walking around with the shunt and you can see the tract on them. Girls, we tend to be able to hide it with our hair because we wear longer hair. So there are some things we got to help the parents understand, that these kids can live normal lives. Do we have to be somewhat careful? Yes, because we don't want to disturb the shunt. Will they need further surgeries? Yes, because the amount of shunt tubing or tract that we can put in them is not enough to grow with the child till they're done growing. So they will get multiple shunts put in. I will teach the families that they're going to have more surgeries. Hopefully those surgeries are only to replace the shunt they have as they grow. However, it's not uncommon for this to be a site of infection because it is a foreign body. And as we know, foreign bodies inside our system are at high risk for infection. So teaching the families how to spot infection is important. Okay, this graft should be familiar for you guys. I'm going to try to scoot it up a little bit. This is in your book on page, I always lose it, 506. These are those early signs and late signs of increased intracranial pressure. These are very important to be aware of. Early signs: headache, vomiting, blurred vision, dizziness, decreased pulse and respirs, increased blood pressure, unequal or decreased pupil reaction time, that sunset eyes, loss of consciousness. Now, our babies can't tell us some of these things, can they? So that's when we're looking at those fontanelles, those sutures, measuring their head circumferences, looking for those dilated scalp veins, and hearing that neurologic cry, high-pitched cry. There is a huge difference. Those late signs, which hopefully we don't get there, but some kids will go from no signs to the late signs, depending on how fast that issue is causing the increased intracranial pressure to occur. The bradycardia, the chain zones, the positioning of decerebid and decorticate, fixed dilated pupils, lowered level of consciousness. Okay? If you don't know these, you should know these, because these are huge when we're doing our neurological assessments. Some other things that we need to be doing. So, level of consciousness. Kids can't always tell us all those things that we use on adults to assess their level of consciousness. But are they answering questions appropriately? Are they following, doing things like that? Looking at the head, face, and neck for symmetry. Checking those cranial nerves. If they're present that aren't supposed to be present, like the Babinskis, that could be a problem. Are they having changes in their motor function, sensory function, ICP, reflexes? We're looking for the size of the skull. Is it asymmetrical or symmetrical? Are they having spasticity of the lower extremities? Because that's not normal either. Are they not reaching their milestones? Or did they meet their milestones and now they're not doing them anymore? These are all signs that something could be going on. Okay, so this should hopefully be a reminder slide. But decorticate is when your body is turning into the core of your system. So your arms are turned in across your chest. And decerebid is that posturing when your arms are turning out away from your body. These are usually very late things that we see with decreased level of consciousness or increased ICP. Promoting child health and teaching. So when we're looking at neurological issues, we need to promote child health and teaching. We need to find out, are they willing to learn? Are they able to learn? What do they know about the learning? If they weren't aware of the diagnosis while pregnant, we need to give them time to adjust to the diagnosis because they're not going to be receptive if they're still in the denial stages. If you don't remember all those different stages of grieving, I would be checking those out. We want to teach in short sessions. We don't want to teach like we do in nursing school for these families. Okay? We're not going to teach in hour-long sessions. We're going to do those 10 to 15-minute sessions. We're going to repeat ourselves and reteach because we don't always catch everything. We need to assess that understanding of the family and that child because we're not only teaching the parents, we teach those older children too, the ones that can understand and learn. Kids need reinforcements and rewards for all their teaching and their learnings and their assessments and their skills. So making sure we're always rewarding them, whether they make the goal or not, they're making attempts. And remember to look at all different modes of learning. So are we teaching by hands-on? Are we reading to them? Are they reading? Are they watching a video? Are they reverse demonstrating? Are they doing those kind of things. Okay, we want to do variety of care teaching and find out what their best or preferred teaching mode is. So some signs that we have a spinal cord injury would be that inability to move or feel their extremities, numbness, tingling, and weakness. Our older kids do get spinal injuries. So do our younger kids. If we've reached milestones, if we've been doing everything correctly, these are good signs that we have something going on. Okay. Structural disorders. Some other structural disorders. Spina bifida occulta and spina bifida cystica, or meningeal and myelomeningocele. We also have muscular dystrophy, spinal muscular atrophy, things like that. We are going to focus on the neurotube defects of spina bifida occulta and spina bifida cystica. And these start on page 805 of your book. So neurotube defects are disorders that occur around the 17th to 30th day of gestation. And guess what? Most women don't know they're pregnant at that point. So that is why we want to make sure we are doing our good diets, nutrients, and all those things, taking our folic acid when we are in those childbearing ages. Females are affected 60 to 70% more of the time than males with neurotube defects. So anencephaly was one that we already discussed. Spina bifidas. People that are higher risk for these, besides being female, are those of Celtic ancestry. Moms that had diabetes while pregnant. Those lower socioeconomic statuses, moms that have to use anticonvulsants, that low folic acid intake, moms that are overweight, and malnutrition. Okay. Spina bifida occulta is a malformation of the posterior portion of the laminae. So this is spina bifida occulta in the picture here. Oops, sorry. Okay, this is spina bifida occulta. I guess I should use the black right here. It fails to close, but the spinal cord and meninges do not herniate or protrude. This form is usually asymptomatic and may not be diagnosed unless we see problems. It is a closed defect, so right here you can kind of see it's closed. It's not visible usually. You have hairy patch, so you can kind of see this kid has a hairy patch of skin, kind of hair right up and through here. If you were to look really close, you can see some hair down in these creases. It's typically around the dermal sinus tract, so right there in the middle. The dimple, as we're seeing here. Now, lots of babies have that dimple right above their little butt. What we're looking at is when I see the dimple, can I see the bottom of it? If I can see the bottom of it, it is typically not spina bifida occulta. It's when I can't see the bottom of it and the dimple goes down further. Okay? Hemangiomas, so those raised red spots, they usually have those as well. They can be along their spinal tract. They can also be on other body parts. Or lipomas, which are also like a growth. Okay, so whenever I'm assessing that kid and I see a dimple, I need to be assessing that, and I need to be charting if there is a dimple, and I need to be letting the doctor know, because we need to determine, is it a closed dimple or not, and make sure none of that spinal tract is affected and used. Spina bifida cystica, which is the meningeal or the myelomeningocele, is when the defect is visible externally. Okay. When we know a child has spina bifida cystica, this child is going to be delivered by C-section and have a controlled delivery because we do not want to rupture any of that exposed spinal, the meningeal sac or spinal structures that are exposed on the outside of the body. Okay? Well, how do I diagnose that this child has meningeal or myelomeningocele? We're going to do, and we'll do this also for this occulta to find out how much is being used or how much of the spinal cord is affected and, under that dimple. We'll do an MRI, CTs, ultrasounds, and myelographs to determine the damage, okay, or the amount of the spinal fluid and spinal tract that are involved. Okay, so this is myelomeningocele. Myelomeningocele is when you have meninges, spinal fluid, and portions of the spinal cord and the nerves are protruding through that sac. This is the worst form of all three. When you have that spinal cord and the nerves and the meninges and all that stuff protruding out of the skin and through a hole and being in this sac, you have higher risk for damage. You also have an increased likelihood of that tract being compressed. And guess what? If that tract in the spinal cord is compressed, fluid isn't able to drain through it. And guess where it's backing up through? The head. So if you notice, the kid's head is a little big in this picture. He also, or she also, has hydrocephalus. Here's another picture of myelomeningocele. Okay, so these are not the same baby. This picture over here is a ruptured. You can see how the sac is ruptured, and now I have a good site for infection. We do not want that to rupture if possible, because now I have direct access to our cerebral spinal fluid, to our spine, to our meninges, to everything, and straight up to in our brain, and we can have lots of damage and issues. Okay? I don't believe I have a picture of meningocele. I don't. Meningocele is going to look similar to the myelomeningocele. Okay, so you're going to see the sac on the back of the baby's back. However, in that sac is just the cerebral spinal fluid and a little meninges. There is no neurotube involvement. So that spinal cord and the nerves are not up and out of that tract. So those are actually where they are supposed to be. Okay, so you just have this sac with a little meninges. Okay? So you can see how where with the meningocele, which is just the sac and so some fluid and meninges that are protruding, that you won't have as severe issues. Okay. When taking care of this kid with myelomeningocele or meningocele, I need to make sure I am protecting that sac. I am not going to allow it to rupture. I am not going to allow anything to lay on it. I want to prevent infection, and I want to make sure this kid is feeding well. I want to make sure they're having urinary elimination. These kids are at high risk for latex allergies as well, so I am going to immediately start latex allergy prevention. So nothing containing latex can be used in these rooms. And I'm going to be monitoring for signs of ICP, or increased intracranial pressure. Okay. Positioning. What did you notice about all these pictures? These kids are prone. That is the best position for them, because if they're prone, they are not going to have any pressure on that sac. Can I lay them on their side? Yes. However, I have to make sure when they're laying on their side, they're not putting pressure on that sac. That sac can dry up. So we are going to put a sterile, moist, non-adherent dressing over it. Okay. And then we're going to cover it with something. I have heard of literally putting a sack from the kids' armpits and covering down to their legs to protect it. And then eventually when the neurologists come up and they do their assessment, they will put this non-adherent dressing that's sterile and moist over top of the defect, and then we'll use like a great big tegator that won't attach on top of the defect but onto the other parts of the skin to protect it. Okay. I am also going to keep the skin around the defect clean and dry. Constantly assessing for signs of infection. I am going to be educating the parents and letting them know what I'm looking for. I'm going to be looking for, are they moving their lower extremities? Are they having reflexes? Are they responding? Because we're messing with the spinal cord. Could we have paralysis, especially with myelomeningocele? Yes. So we're watching for these things. We're assessing for the damage before we have surgery. Yes, these kids will get surgery. They are going to have the defect reduced. How soon do we do surgery? It varies. We try to do it within 24 to 48 hours after birth, because the sooner we do it, the less likelihood we're going to have rupture and damage. I'm also going to do good thorough head circumferences of these kids as well, because guess what? They could be at high risk for hydrocephalus. I can feed this kid up until surgery, until like 10 hours before surgery. If mom wants to breastfeed, they can breastfeed. I will just lift them up on a pillow and put that pillow on mom's lap, and they'll just feed with their head turned to the side. I can bottle feed them the same way. I am going to rotate them slightly to take pressure off of those extremities and bony prominences. However, I want to be careful that I don't cause any damage to the sac. After surgery, they will stay prone for a while till we know the site is healing. And then eventually we will be able to put this baby on his or her back. It will take a while, but eventually we will get that done. If this hydrocephalus isn't bad, if the defect isn't bad, these kids could have pretty normal lives. If we're seeing that there's some lack of movement or weakness in their extremities, guess what? We're going to get PT and OT involved, so that maybe we can strengthen those muscles and strengthen the use of their extremities and hopefully reverse some of their defects. Okay, so kids with neurological issues can have complications of immobility. So as we know, people that are immobile, we need to be repositioning and turning them. Just making sure we're avoiding those areas that we're not supposed to have them laying on. Doing our good skin assessments for redness and warmth and breakdown. Doing our range of motion exercises, so I will move their legs and their feet, their arms. I keep their skin dry and clean. Make sure they're staying hydrated. Little ones, we can't cough and deep breathe, especially our babies. But our big kids, we can get them blowing on pinwheels. We can get them blowing on cotton balls. Whatever it is to get them to take a deep breath in and blow it out. One thing I forgot to mention with our myelomeningocele and meningocele babies is poop tends to explode everywhere. I will put a plastic surgical drape that has like a stickiness, just Have it turned so that the sticky part is just above the opening for their rectum. And then I have the drape then laying up and over their bandage so that if some poop would get out of their diaper, it would hopefully then just get up on top of that drape and not get anywhere near that dressing, and hopefully decrease the likelihood of having a dressing that's damaged and having to mess with that site at all. So, spinal cord injury. How do we prevent it? Well, education, right? So, vehicular safety. Teaching parents how to use car seats. What ages to use them in. Safety belts. When to get rid of safety seats. How to use appropriate bicycles, sports, recreation safety, wearing our helmets, our protective devices. How do we prevent falls? Picking things up, right? Blocking stairs. Talk about gun safety and violence prevention. Our water safeties. Not diving in those shallow waters or at night or when we're impaired. I will let you guys talk about some of these things in your presentations on prevention of issues. But once again, we always need to be teaching our families so we don't have further. Okay, we have a lot of acquired, and this is kind of some FYIs for you. We have a lot of acquired neuromuscular disorders. So due to our spinal cord injuries or birth trauma, head trauma, which you guys will somebody will be talking about. Autoimmune diseases can lead to neuromuscular disorders. So like Guillain-Barré syndrome, myasthenia gravis, and botulism can too. So just be aware that other things can cause these issues. So when we are taking care of a patient that we think has a neurological disorder, we need to be observing for all sorts of different things. We need to find out what changes in their gait they're having. Are they having recent trauma? Poor feeding, lethargy, fever, weakness, alterations in their milestones, weakness, alterations of muscle tones, sensory changes, things like that, because those can give us a good history of what's going on. We need to also re-ask questions multiple times to make sure stories don't change. Because guess what? Some things do change. We don't always get the true story, unfortunately. Okay, when we're doing that physical exam, inspection, observation, so looking at the motor function, doing our reflexes, looking at our sensory function, okay, palpating the muscle strength and tone. Remember, when we're doing these things, when we're palpating, when we're doing things, we need to be doing both extremities at once so I can compare them at the same time. We can't just assess one side because that's not going to tell me if there's something wrong with the other side. Always assess the lung sounds because our nervous system can affect our ability to breathe as well. So lung assessments always need to be done with neurological assessments. Excuse me. Preventricular hemorrhage and intraventricular hemorrhage. I think this is better found in your Ritchie book on chapter 24, if you're not finding very much in your Kyle book. This is bleeding in the brain due to the fragility of the cerebral vessels. So our babies, especially our premature babies, those cerebral vessels are very fragile, very tiny. They break easily with pressure gradient changes. Okay, we have hemorrhages that can be graded from 1 to 5, and that is all due to the amount of bleeding that is occurring. When I'm assessing the kid, I may not see any issues. Some risk factors: precipitous birth, being premature, head injuries, vacuums. That's just to name a few. Things that I might see In my assessment are that unexplained drop in hematocrit levels, pallor, poor perfusion, a child that's having seizures, lethargy, weak suck, that neuro cry, and they're hypotonic. How do I find out they have this hemorrhage? Ultrasound. I gotta look at that brain, because that brain is going to tell me everything. Okay, and then we're going to see how much fluid is built up. We also need to make sure that some risk factors are when I have a child that has like arterial lines in and or I'm pulling, or even any blood lines that I can pull blood off of, I need to make sure when I'm pulling blood off those lines, I'm not pulling the blood off very fast, and I'm doing it very slow. I also want to make sure I'm not giving them fluid and pushing fluid in too fast either, because that causes big changes in their levels of perfusion. And that could also cause some hemorrhages. Prevention. What can I do to prevent? In our preemies, some places have it in place that once a preemie is born, depending on how many weeks they are, we have some things set up. So the really little ones, we don't turn them, or we don't completely turn them. So we like to keep that spinal cord in a complete alignment for up to like 2 weeks. We don't allow the parents to hold them, because if I turn and don't keep that spinal cord in alignment, if I were to pick the kiddo up and raise the head of their body too high compared to the rest of their body, so sitting them up, that causes a big change in their pressures. So that's one of the reasons we don't always allow them to hold for a couple weeks. We want to make sure I'm following their blood levels closely and their blood pressure, and making sure if I'm seeing any signs of anemia, I'm correcting it quickly. Same with the acidosis and hypotension, so making sure they have enough fluid going through, but I also want to make sure I'm not filling them. The flex contain position, so I could flex them a little bit, so I'll keep them supine. And then I will just, as long as their body is in alignment, their spine is, I can let their arms kind of come up across their chest, and I can pull those legs up so it's up against their chest or up and bent a little bit. I'm also covering their head a lot and following it to make sure that they're not having fluid buildup in their brain, right? Cluster cares, because if I do tons of things to the kids, guess what? I'm stressing them out and I'm overstimulating them. And I always prepare the parents that if I have a brain bleed, that could be causing damage to my brain and causing some of that tissue to be broken down. And if I have tissue that is broken down, that is going to affect my neurological functioning. Now to share some stories with you guys. I have taken care of several kids, and it's amazing how much a baby's brain can correct itself and fix itself. Okay, I want to throw that out there right now. I have taken care of several kids who've had like grade 3 or grade 4 brain bleed, and the brain bleed had reabsorbed and goes down to grade 1 or disappears completely. And some of these kids have had very minimal to no issues at all later in life. Okay. Recently I took care of a kid that had a grade 5, and we reassessed it right before going home, and it was completely resolved. That is pretty rare. I am curious how much brain damage that child did have, because I'm assuming with a grade 5, he probably had some. Okay? These kids will get PTOT, speech therapy, long-term care. Can they function with their other peers? Yes. It all depends on how much neurological damage is occurring. They can walk around. They can do math. They can read. It all depends on where that damage occurred, on what their outcome's going to be like. So what can we do is just make sure that we're not causing those big pressure gradient changes in their blood system. So following them closely, assessing them, and not doing those major frequent changes of their body system, position changes, things like that, until we know that it's a safe time to start moving them. All right, that should be the end of this PowerPoint. And if you have any questions, feel free to ask me in class or email me. Thanks.